Great, thanks. And oops, okay, get the recording out of the way. Um, yeah, so a couple things. So I'm Larry Wisso. I'm a child psychiatrist, formerly a pediatrician. On the faculty here at the University of Washington in Seattle. And if it is a small group, I really would love folks to just please break in. It's either through the chat or by unmuting and saying something, because that makes it a whole lot more fun. So I want to follow up on this idea of being solution focused in a transdiagnostic approach to mental health. And in some ways, the real hidden agenda here is to convince everybody that you really have tools to address mental health problems, even if you don't feel like you have necessarily the expertise to make a diagnosis, or you don't feel like you have advanced psychotherapeutic skills. There's a huge amount that you can do with your general toolbox, whether that's in primary care or even whether that's in specialty care. So quickly, just to get some acknowledgments out of the way, I've learned this material from a whole bunch of different people, uh, partly through some research grants and partly through just many collaborations. And none of it's original. I'm packaging material that I've learned from many folks over the years. And I have no disclosures of conflicts of interest. We won't be talking about off-label prescribing suggestions, and all of this work's been funded through public sources. So last time, if you were here, we talked a little bit about what's a transdiagnostic intervention. So something that uh, is likely to help across any number of formal diagnoses and therefore is safe to do, even though you're not exactly sure whether this is anxiety or is this depression or is it a little bit of both or is it attention, that you've got something that has a good likelihood of helping and a very low likelihood of harming, no matter what combination of those things it is. And we talked a little bit about how people, when they're stressed, change their thought processes, and that really the goal for us when we're trying to do really any kind of clinical care, but especially mental health related stuff, is to help move people back into the place where they feel that they are more calm, uh, a little bit more self-confident, and therefore can really use all of the cognitive capacity that they have, rather than be in a very sort of stress and trauma focused mode. And we talked a little bit about sort of setting the tone for a visit to try to help that happen and getting an agenda out on the table. And so this time, what I want to do is talk about how, okay, you've got an agenda on the table, you have potentially a, a general problem. How do you focus that down to be an actionable problem? And then how do you take that problem to find a solution? And again, one of the things that's really important about doing this is to think about how you can be working with the family on coming up with a solution. The burden is not entirely on you, that this is really a joint effort. And that's always a huge relief to me, because it's really hard to come up with solutions for other people if they haven't tried already. So what is this idea of solution focused therapy? The theoretical side of it is that what we're trying to do is we're trying to turn things around from saying that we're the expert and we know what would be good for you, to see the world through other people's eyes, so that they are looking at what's possible, what's been problematic for them, and what they feel would be the right way to move forward with whatever the particular difficulty is that they have. And what we want to be able to do then is to be a good guide for that. We have the perspective of not being directly involved. We have a big toolkit of possible interventions. We can give them advice about some of the things that they've thought about doing, but we really want to get out of the idea that we just offer advice. It's more, can we help jointly develop some solutions and then together think about which of those might really work. And this, as if you are able to do that, is really inherently strengths-based, because you're really asking people to think about what it is that they've already done, what it is that their intuition tells them would be a good thing, what do they know, what what do they think they're, have resources to do, and helping them put something together based on those strengths, rather than saying, okay, we've found a bunch of problems you have and I have the solution for them. And the really the key questions, which we'll come back to over and over, are these two at the end of the slide. One is, what's worked in the past, even if it's only a little, and how can we recreate those conditions or make that better? And it really, it's almost the same question, just asked differently. When things were going better, what was different? And again, how can we get back to that place? Okay, so if we're going to do that stuff, the ideally we want to apply it to what we'd call an actionable problem. So lots of us have problems, but they're not always framed in a way that allows us to know what we might actually want to do about the problem. And in particular, especially when we're dealing with sort of parent-child, kind of issues, kids get asked, or parents want kids to do things which are actually very hard to assess, and are very much often in the eye of the beholder. And sometimes that's the whole problem, is that one person thinks they are showing respect, for example, and another person doesn't. So things like, I want my kid to have a better attitude, or I want my kid to show respect. Um, you know, I want my kid to not be so mean, to their little sister. Um, those things, it's true. We want to change those things, but they're very hard to measure, and therefore they're hard to change. So we want to have really concrete goals, if we can, that lend themselves to something that we can observe, so we'll know when it's happening and when it isn't. um, B, that it's a positive thing that we want somebody to do, and thirdly, that it's something that somebody really knows how to do. So this concrete, and it's measurable. So an example would be, I don't want him to storm out of the house, um, you know, when he's angry. Uh, how would you flip that around? You would say, I would like him, even if he's, feeling upset, to close the door gently. Um, this is a good place to stop. Does anybody, um, who is listening, or part of this, have an example maybe of sometime when a family has brought you one of these sort of vaguer sorts of concerns, and um, should we take a second and think about how to try to convert it into something more concrete?
This is a time where you can unmute yourself. You can turn your camera on as well and volunteer a scenario that you might want to work through.
Oh, okay.
Kennedy.
Kendra says it's new to. Okay, all right, great. Well, um, one thing I could think of, let's think of in the care coordination realm of when, uh, Kennedy, I don't mean to put you on the spot, but you were kind enough to jump into the chat. I mean, do you ever have, families when you're trying to do, uh, care coordination, either say something about another family member that, whose actions or attitudes are being a barrier, um, or anything, anything along those lines? Or do people bring you problems, when they, let's say they're trying to access a service or something that you've tried to hook them up with? Maybe not. Well, we'll keep thinking about it. Well, I'll move on here, but if anybody has a good thought about this, please jump in. So, oops, oh yeah, okay. Have a patient who's been living without water and refuses all the help and suggestions I've been giving. Oh, great. Okay. So that's a perfect thing to think about here. What and can it's fine to be off camera. Can you talk to, or do you want to just do the, if you want to just do the chat, that's fine. So what does this person say when they refuse? Or what's their refusal? Okay, no worries. You can just type. Okay. Um, so he doesn't and it's the idea he's saying he doesn't want to be a burden to other people. Maybe I'll read this because I don't know in the recording whether people will be able to see the type. So Kennedy says that this is a person who that they've been trying to help, who's been living without water and refuses help and suggestions, saying that he doesn't want to be a burden. So what is he? Who is he worried about being a burden to? Do you have a sense of that? I realize that every question I ask takes longer to type an answer to. So so while Kennedy's typing, one of the things that we could say here is that, so one of the interesting possibilities is that there isn't a shared understanding of what the problem might be. So Kennedy, I'm just going to sort of put some words in your mouth. Let's just say that you've encountered this individual. Oh, okay. So the gas station gives out free shower tickets, and we've offered those. He just says he doesn't want to be a burden. We aren't sure to who. So there are a couple of interesting, possibilities here. The one, if I put on my psychiatrist hat, the thing that I would think here is that this is one of those situations where, despite our wanting to help people, that our wanting to help people makes them feel like they are going to have to be in this position of accepting, whether, I don't know if you want to call it a handout, accepting help. And in that one down position, it feels better to them to do without something that they probably would actually really like, than, in this case, either to feel that they're a burden or to feel that they're disempowered. So I think one of the questions that we could think about, and maybe what we can do is circle back to this at the end, is how we could have a conversation with this individual where our goal is still to get him to do whatever the steps it takes to get water turned on where he lives, but to have him do that from a position of strength, to have him think about how he would like to solve this problem. And it may be that also part of the issue is that we're not on the same page about what the problem is. In other words, maybe he doesn't think that it's a problem. He doesn't need water to get a shower because he can go to the gas station and go to Cenex and get his free shower ticket. But maybe there is another issue that he would be willing or is interested in solving that would get him, that would then say to him, yeah, if I want to solve that problem, then it's worth it to me to go out and ask for the water, because in that case, there's a really good reason for it. I'm not just being, it's not a burden. It's not filling in, for something that I could sort of do anyway. And this is maybe not a bad place to get to this next slide here of going sort of from the problem to the solution, is asking to move on to the next step. Because again, I think what Kennedy's pointing out here is a situation that so many of us get into, which is we think we know what the problem is. We think we know that people are ready to do something about it, and we give them a solution, and then they say, well, no, not really. So how do we make sure that we're on the same page? And again, Kennedy, I'm totally running with this in my imagination. So I'm sure you've approached this in a really wonderful way with this person. But what we could do more generically is to say, okay, I think I understand, what the problem is here. Your child is irritable all the time, or you can't get them to study. And let's pick something that's more back in our sort of realm here. Thanks a lot. Okay, I'll keep running. And and we could say, well, are you ready to, would you like to hear what I'd like to do about it? Now, it's possible in this particular case that the guy, who needs the water would say, nah, that's okay. I don't need any help with this. And what you could do is then you say, well, I'm sort of curious about that. I'm gonna sort of can I sort of tell you a story here? Here's this guy, and I mean, I understand that he can just go down to Cenex and take a shower, but it puzzles me that we I can't what do you do about your dishes? What do you do about X, Y, and Z, other sorts of things? And uh, it's really amazing that you're able to sort of get by without this stuff. But tell me a little bit more. And some of this is this motivational interviewing approach that I'm sure you're also familiar with, which is just sort of trying to not butt heads with people, but at the same time to be really clear about, gee, I'm puzzling about this. There must be something I'm missing. Tell me more about the situation. And maybe what we would understand, here is that either this person, it could be anything. It could be from I actually like going down to Cenex because I get my free shower, and then I spend an hour having a coffee with the guys who hang out down there, and if I could take a shower at home, then I wouldn't have a reason to go down to the gas station. Or if I had a shower at home, then my sister wouldn't give me a ride to the gas station. So one of the big things here is to you think the problem. You want to check in on whether you actually are on the same page with the problem. You want to make sure that the person has the sort of motivation to do something about it, and you're not missing what that is, but that you're optimistic that you can sort this out in a way that'll be a win for everybody. That's really what you want to get across, this optimism that you can, there are ways out of this. Okay. Whoops. So I said that we would talk about this, over and over again. When people come to you and they're feeling, stuck, or you're in this position, this is the most important thing. You're in a position where you don't want to just throw out ideas because you know that these folks are just ready to sort of tell you that that's not going to work. What do you do? Um, Fortunately, we don't have to all say how old we all are here, but at least in the old days when I did my water safety instructor training, when I was, wanting to be a lifeguard when I was in my, and teens, they talked to us about double drownings. And I don't know if any of you are familiar with this idea, that if you've been a lifeguard, but the idea is that, someone's in the water and they're, saying, help me, help me. You don't just jump in and try to pull them to safety, because they're going to grab you and they'll pull you down too. That's why you have your big stick, or that's why you paddle out and shove somebody something that floats or something. And what we don't want to do in these situations is run into Kennedy's guy at the gas station, who basically says, no, you can't help me. And no matter how many things you throw out, I'm going to say, I tried that, didn't work. And eventually, you just end up being as hopeless as they are. We don't want to do that. And at the same time, we want to make sure that these folks feel empowered to come up with a solution that they can feel proud of. So assuming that you're now on the same page about what the issue is, we want to ask about, what was the thing that has worked in the past, even if it was only for a little bit. And almost everybody will have some time that they can say that whatever this problem was, whether it's with their child, with their partner, with something in the community, that there was some time in the past when maybe things were a little bit better. And so you can say, what was the thing that worked best? What were the exceptions? There are a million ways, around this. And another really good question that's very empowering is, well, despite all these problems, what's made it possible for you to continue to manage? Where do you get your strength? Who are your supports? And folks will, hopefully most of the time, be able to come up with both resources that they hadn't thought about, times when things were better, times when they actually did feel like they were in control of the situation or had been effective. And this is going back to that stuff that we talked about last time, of being able to sort of shift your thinking, that when you're pessimistic, when you're feeling stressed and negative, it's really hard to remember these kinds of things that we're asking about here. And part of the whole goal of the beginning of the visit is to get people into a position where, if you will, they even dare to sort of look backwards and say, yeah, it hasn't always been so terrible, and here are some things that might work. So then your next step is to say to them, well, if that worked in the past, or there was an exception, what's some tiny small thing that you could do now that would put some of that stuff, back into motion, the way it used to be. So let's say I've got a kid who, right now there's a really huge sort of, fight about doing homework. And, we don't know if this kid is depressed, or whether they have ADHD, or whether they're really anxious about something. And to some extent, it doesn't matter, because the first thing that we actually want to be able to do is to help that child and parent not have a big fight over doing the homework. We want them to be able to feel that they can sit down and do even just a little bit of it and get a taste of that success. So, so let's say that this a parent in this sort of homework situation says something like, okay, um, there was a time, last year when for, a little while, um, he was willing to sit down and tackle his math. Uh, but this year, it just doesn't seem to work. So you say, well, what was different back then? Well, there could be a couple of different things. I mean, one is I think the teacher was better at, giving them, problems that were sort of on their level. But, also, I wasn't as busy last year. I didn't have to um, work as late. So you could say to somebody, okay, well, what does that give us as as an opportunity here? I mean, could you uh, either work with his teacher and or even just yourself, take a look at some of the problems and say, okay, which are the easy ones here? Let's start with those. And is there a way for you now to block out, even if it's only 5 minutes or 10 minutes, to do one or two of the easy problems with him? So that would be some, first step toward working on this homework debacle. And again, we don't know whether this is anxiety, we don't know if it's depression, we don't know whether it's ADHD, but the first step in all of those things would be to help the family feel like, okay, we don't have to fight about this, and I can help my kid regulate his emotions. I can help him learn how to plan. I can help him do all of these sort of very psychotherapeutic things, but in the context of just this really first simple little step. Um, and then I think what we want to sort of what I'd like to switch to in a second is all of the things that are really in your existing pediatric, or primary care toolkit for um, helping families that does not require a huge amount of knowledge beyond what you've already got, which is considerable. And we'll walk through each of these. So one is connecting with parents. The other is reducing overall stress, looking for treatable comorbidities, working on parent-child interaction, helping kids self-regulate, and helping children learn how to solve problems. So we won't go into a lot of depth on all of these, but I want to touch on them because it's stuff that you do all the time. Um, whether you're case managing or whether you're, actually doing primary care visits. And these are immensely powerful things, especially when applied to a problem that the family has identified and agreed with you on is something that they want to do something about. So what are some absolutely universal things? So one is connecting with the parent as well as the child. I think we've probably talked about that before, is that that we need to, even though if these are pediatric visits, we don't want the parent to be there just as somebody who feels like, right now, I think somebody only cares about my kid. We want to hear the parents' distress. We want to validate the parents, and we want to make them feel that we've connected with them. The next one, and this is Kennedy's bailiwick for sure, is attention to context and basic needs. So what else is the family juggling? Um, I'd say in half or three quarters of the sort of child mental health issues that come up in primary care, the main underlying driver is stress on the family in some way. At one extreme, it's housing or food insecurity, or worrying that the utilities are going to get cut off or they already have been. Um, but it can also just be stress between the parents. It can be stress at the job. It can be an overloaded, schedule. So how do we understand what that is and help people to unpack that? Um, what are some of the comorbidities if we're thinking about mental health stuff in particular? Does this child have a developmental problem that hasn't been either diagnosed or addressed? and schools are a huge thing here. Even if a kid has an IEP, maybe the IEP is actually not being implemented. Um, and then looking for ways to decrease, stress overall. So that goes along with the basic needs. Okay. Um, how about, parent-child interactions are at the root of practically every child mental health problem. Um, sometimes they're the primary thing that is really causing the mental health problem. In other words, the child and the parent are at odds about something, and that leads to the depression or the anxiety. Sometimes the depression or anxiety makes a kid irritable or a parent unavailable, and that then leads to the difficulties in interaction. It's a two-way relationship, and it doesn't matter kind of which direction it's going in. If it's a treatment to address it. So, what are three or four things that you can apply to almost any situation, no matter how old the kids are? So, if the children are anything past infancy, having clear and consistent sort of rules and routines as much as one can, um, is a universal positive intervention. So with infants and younger children, that falls into the routine kind of a situation because kids are always looking for, predictability, as are we all at some level. Um, it's more explicitly around these are the rules, and this is what I expect as you get older. Um, Minimizing punishments and maximizing positive interactions. That's always a great thing to talk with families about, and just say, yeah, I mean, punishment's important, but we want the majority of the behavior change to come from people actually doing it because it feels good. So how can we have more positive interactions and have fewer negative ones? And there is a particular way of having more positive ones, which is just to say, no matter how busy I am, how much special time or uh, uh, how much child-directed activity can I have on a regular basis? Ideally, something every day. It doesn't have to be more than 5 or 10 minutes necessarily for school age or older kids, but some period of time that um, the child can count on the parents' more or less undivided attention. And then reach out and read. Are all you from everybody familiar with that? Probably. So a program that's in almost every pediatric practice these days, which at its simplest just involves we have a bunch of books and we give them away to people, but it not only helps promote literacy, but it's a wonderful activity. So if the kids can get to pick a book out and the parent commits to reading that book to the child, uh, you've you've just done a really big intervention into having positive activity. So that's one set of universal interventions. How do we help kids self-regulate? Because when you think about it developmentally, that's one of parenting's most basic uh, sorts of needs, actually. I mean, when we come out and when we're born, our ability to sort of regulate our emotions and behavior is very imperfect. And it is through the back and forth relationship with our parents that we really learn how to do this stuff. So a couple of things that you can always um, give to families as advice. The first is this idea of scaffolding or giving people a heads up. Uh, how do you sit down with kids either before a whole day or a part of the day and just walk through what's going to happen, and help them mentally prepare for it? And if there's something that's going to be hard, you can help them try to actually prep, uh, think out what they're going to do. Can you give kids just a little bit of extra time to stay organized and oriented? Um, okay, I think you're likely going to be bored because you're going to have to wait in the car for me while I do X, Y, or Z. What could we, what could we bring along? Um, I know that sometimes, you get a little anxious when you, you get out to the, playground and there's more than one school bus. How do we think about making sure you get on the right one? Um, how do you help kids read emotions in others and name them in themselves? Uh, there are lots of ways to do this, but a lot of, you know, people watch television or now, things online together. And that's a great way that parents can say to kids, oh, that person looks angry. How did we know? And that making sure that parents know how to help kids calm down. So how a parent can, when they can see that things are heating up, they automatically, or not automatically, they know how to sort of slow themselves down, how to start to speak a little bit more calmly. They know to sort of take a deep breath themselves, and they can teach kids how to do this stuff. What are some comforting rituals that the parents and kids can do together? Um, what are the things that parents can do to just say, okay, maybe we just need to play a game right now, but something that will help bring everybody back to a place where they can, like we've been saying, think a little bit more clearly. Um, a really big way to help kids, especially who are anxious, is to help them break tasks down into manageable parts. So this is a big one for homework. This is a big one for, you know, people saying, "Oh, I'm overwhelmed. There's so much to do." Um, how do you do a lot of out loud problem solving? How do parents talk about this could be a parent who's, trying to model that. Yeah, things can be complicated, but I can think my way through it. So maybe everybody's being really busy. It's after school, people are home. Someone's got to do their homework. Someone's got to help prepare a meal, and somebody can start to say, "Oh, we have so many things to do. Let's just think for a second about what we're going to do first." And um, I've got to make the casserole. What am I going to get out of the cabinet first? Or let me sit here and think about what I might have to, all the ingredients I might have to do to make this cake. Um, so what you're doing is just doing the same old stuff that you would normally do, but you're saying it out loud so that your kids get this idea that there's a mental process, and that no matter how hurried you are, in fact, even maybe when you're really in a hurry, that's when you most need to sort of sit down and break things out into manageable little pieces. And then there's the whole issue of mindfulness. Um, and people have many, many different ways of approaching this. Uh, a big one with kids who are sort of all over the place is, remember, safe body first, which is a nice way of saying, obviously, try to sit still and keep your hands to yourself. Um, do you take slow breaths? Do you think, yes, I want to, remember my teddy bear, or something that I'm visualizing. There are a bunch of these, and we could go through them if you want to, but they'll be on the slides. Um, so the idea to finish up with this solution focused work is, we've identified a problem. We've helped people try to come up with some couple of simple things that they would like to be able to do, and we've tried to reinforce that with some of this sort of universal toolkit that we've just talked about. And now we want to get them to focus on the next steps. So the first thing is, okay, how we know it's going to be better? So what's the problem right now? So the problem right now, let's say, is Larry has tantrums around his homework. And we're going to rate that on a scale of 1 to 10, where 10's like a really bad tantrum and 1 is there isn't any. So where is it now? Okay, it's 7. Um, what are we going to do? Well, we're going to try this idea of looking at the homework and saying, okay, we've been successful if we've done, one easy problem, uh, and that's our first step. We just want to do one easy problem without a problem. Okay, good. Um, you know, how are we going to rate? How will we rate that? Does that mean it'll come down to a 6 or something like that? Good. All right. Now we're going to check in on this in a week or 2 weeks, and did we get to where we want to go? And if we did, what do you think we'll try next after that? And the goal of this is to move things forward in, if you will, bite-sized pieces where people feel that they're increasingly confident that they can handle these things themselves, and where they feel that they don't need to come back to you, but they could if the problem comes up again or they want to make it even better. It's really super important to come up with a list of barriers as well. So if someone has agreed to try something, it's always worth asking this last question of, are you sure that you could really do this? Could anything possibly get in the way? Because over and over again, we find out people saying, yes, I mean, I'd love to have that prescription, but then find out they can't get a ride to the pharmacy, or their insurance has run out, or they don't have the money for the copay. That's just even one set. And I'm guessing, Kennedy, I'm still picking on you. You run into this stuff all the time when you're trying to do care management. Okay, so in the end, if we want to sum all this up, what we're trying to help people is to sort of be able to use information from the past to really think about the future, to be prepared for change, and mostly to feel positive and capable about themselves, so no matter where they are, that they feel that they've got the support, but they also have the inner strength to be able to move on to the next thing that they really want to try to do. I'm gonna, in the interest of, I think we've recapped enough here. I think this is a really good place to stop and just say, does any of this resonate with stuff that you already try to do? Are there questions you might have about it? Anybody have a good story about how they helped somebody who seemed pretty hopeless about things to be able to find a way forward? And anything you want to touch on? And I'm going to make the slides go away here so the few of us can see each other.
One of the things that has emerged as we've been doing the PMHCA program, and I'll just give this out as people start to think about their own scenarios. Our coordinators, our care coordinators for the PMHCA program, have identified, and as well as have other family voices across the country identified, that pediatricians don't always refer to care coordinators because they don't believe that they need to have, or they don't need assistance. But when they actually get to speak to a care coordinator at Family Voices, they've identified a plethora of needs. And the family's response to not wanting to necessarily share those with the pediatrician or at the clinic is fear that they would be turned in for neglect. If they didn't have water, if they didn't have heat, if they didn't have food resources.
Yep.
But when they are in contact with the care coordinator, the care coordinator, much to what you were saying, gives them the ability and the time. This is what I'm here for. We can work through these things, and then reaches out to get those resources, and partners with the family to do so. It just strikes me as how often the family fear, logical or illogical, that is what they experience.
Yeah. So since we have at least one care coordinator on the call, what advice should we be giving to those pediatricians so that they can get more of this stuff out on the table? Because it's really super important. I mean, a lovely example, I don't know if it's lovely, that's the wrong word. An example that I would give where having the information that the care coordinator, someone like Kennedy, is able to get would just be vital. Is I don't know how many times I've done my little song and dance with a family about, a child's sleep, for example, where we're saying, yes, you should have a bedtime routine, and uh, et cetera, et cetera, et cetera, only to find out at the end of it that the family's unstably housed and they don't sleep in the same place, 2 nights in a row, uh, or that they're actually sleeping in a shelter or a car even. And so all of my advice is not only silly, but I just wasted a huge amount of time that I could have spent, trying to help the family in some other way. So knowing that it's really important to get these things out on the table, what would our advice be to the pediatricians so that families wouldn't be so fearful about disclosing to them? I mean, I have some things up my sleeve, but okay. Kennedy says, I think they need to know how much we can help them. I'm new in clinic. I work at only 2 out of 9 providers. I work at, and only 2 out of 9 providers have been willing to use me and my resources, which has helped me quality of care for their patients. They need so much more information about how useful we can be. Yes.
Oh, yeah. Even for pediatricians to be able to introduce to their client, to their patient, that we work as a team, and introducing that next step of the care coordinator.
In these sites, is there screening for social determinants of health? And I know people don't like the word determinants these days, but social whatever.
I think some sites are doing them. I don't know if anybody on the line wants to add if you're doing them, but I know it's inconsistently being done across the clinics in the state.
We actually just within the past few weeks started implementing social determinants of health in my clinic. We are a family practice clinic, so not just pediatrics, but it's been going really well so far. And we put together a list of local resources and things that we can give to patients that score positive or high on the social determinants of health. And that seems like it has been going really well.
That's great.
Excellent.
Well, and one thing that I think goes to what Jen was saying is, how is that questionnaire given out? How, who gives it out, and how do they frame it so that people understand that exactly as you say, this is not one of those things where if you check off enough, we'll take your child away. We're really interested in learning learning about this so that we can be of help, not so that we can hurt. What's the language that people are either using or you think they should use as they introduce it?
So I don't know if this is the right way or the wrong way to go, but we started initially asking the questions in the exam rooms the nurses would ask, and then the providers would follow up if they answered that they were having struggles with anything. But we have now started to have the receptionist at the front desk hand out a form for them with all the questions right when they check in. And people seem to, at least from what I've gathered, be a little bit more honest when it's on the paper. They don't maybe fear the judgment of saying it directly to their nurse, especially in a small community where they likely know their nurse on a personal level. It seems like they might be a little bit more honest on the paper. And we have an option on there to write patient unsure or patient declines as well. But that seems to be really helpful. And then expanding the conversation if they do answer that they're having struggles with any of those after that.
Well, and that's really what you say is really consistent with some stuff that goes back a long way, which is that as for sensitive topics, people often are much more comfortable answering a computer or a piece of paper than they are, somebody, right in front of them. I mean, do you think that uh, any additional things like, of course, we will keep this all confidential, or I mean, I know that that's hard in a place where everybody knows everybody anyway, but anything else you think, or do you think it's working well enough, I guess, because that, that's another thing about questionnaires is one way that they're very valuable, because even if people decide to basically not be completely forthcoming, you've at least put on the table that this is something that you care about. And a good follow-up question for all of them is always, well, is there anything this made you think about, even if we didn't ask about it directly on here? Because so sometimes people will come up with another need that's sort of related, but you're at least opening the discussion.
That's a really good idea. I like that idea of adding is there anything else you're concerned about, or anything else you'd like to talk about question at the end?
Mhm.
That's a good idea.
Mhm.
I think we'll add that.
Yeah, great. Any I guess an question would be is, are there other opportunities for trying to be sort of more empowering in our work here, and as opposed to or being risking offering solutions that that people don't want, or even if they need them, but that they're gonna turn us down for, like Kennedy's guy in water. Oh, neat. Meeting with the school. Uh-huh. Being, what did the school, what did they come up with? We're forcing Kennedy to type here. So.
I think it's a very proactive move in order to intervene at a really low level of need, hopefully, and to assist at that lower level before things begin to escalate.
Well, and I think going back to the whole, care navigation thing too, I think that's it's so important. The same way I think that we're trying to be solution focused with our patients, we need to do that at a system level as well, and with our colleagues. I mean, part of the whole idea of this is to see things from other people's perspective and to find solutions that fit into uh, their perspective of the way things work in the world. And I know that one of the surest ways that I, as a child psychiatrist, can fail my patients is to, call up a school and sort of imply that they ought to be doing something, as opposed to call up the school and, and basically say, you're a colleague, you see this child, for hours and hours a day, and I want to be able to, we want to put our heads together and think of how you can help them in your setting, and I can help them in mine. So Kennedy writes, they express the need to help parents understand how to help their children, plan a parent night with psych providers and family provider to give parents tools to help their children cope, and give them tools to cope themselves. Perfect. So that's really great. So to have them invite you in that way is so wonderful, and that can only be good for being able to help doing co-treatment. I mean, you know, that's fantastic. Well, I think we're out of time. I want to especially thank Kennedy for and the list, but Kennedy especially for typing and providing so much really fun, thoughtful stuff. And Jen, thank you for jumping in.
Always.
Okay, well, good to see you all. Take care.
Thank you
Let
so
me know
much
how
for
everything's-
that great
Okay,
presentation.
it's fun. All right, thanks. Bye.
Thanks, Dr. So we'll follow up on the other issue on the
Okay.
impact. I will send to you.
Great, thank you so much. Thanks. Bye.
Thank
There you
you.